Electrocardiograms, ECGs. Cardiac Wellness Institute of Calgary. Updated May 2010. Material to be covered. ACSMS Resource Manual for Guidelines for Exercise Testing and Prescription, 6th ed. Chapter 27. Rapid Interpretation of ECGs, 6th ed. Lead Placement Standard 12 Lead ECG. Limb leads, 6 in all, 1, 2, 3, AV. Chest leads, 6 in all V1, V2, V3, V4, V5, V6. Limb leads, 3, 2. I. Bipolar. Plus. Dash. AV. Augmented. Plus. AV. Along the horizontal plane. Chest leads. Along the horizontal plane. V1 and V2, right side of the heart. V3 and V4, intraventricular septum. V5 and V6, left side of the heart, process. SAR node, heart pacemaker, located in the RA, initiates next step. P wave, atrial depolarization and contraction. Process. P wave, atrial depolarization and contraction. Process. Avenue node, slows the depolarization of the atria, connects atria and ventricles electrically. Process. QRS complex, ventricular depolarization, begins in bundle of His. Process. Ventricular depolarization. His bundle, left bundle branch and right bundle branch Purkinje fibers. Ventricular depolarization. Q wave, first downward wave of the complex. R wave, first upward wave of the complex. S wave, downward wave preceded by an upward wave. Process. Saint segment, initial plateau phase of ventricular repolarization. Process. T wave, rapid phase of ventricular repolarization. Normal ECG. Rhythm. Normal sinus rhythm, each P wave is followed by a QRS. Regular or irregular. Rate P wave rate 60 to 100 BPM with less than 10% variation, normal. Rate less than 60 BPM equals sinus bradycardia, results from excessive vagal stimulation, SAR nodal ischemia, inferior ME. Rate greater than 100 BPM equals sinus tachycardia, results from pain, anxiety, CHF, volume depletion, pericarditis, chronotropic drugs, dopamine. Rate. Methods. Method 1 equals 1500/ of small boxes between RR. Method 2, P wave normal, height less than 2.5 mm in lead 2. Width less than 0.11 s in lead 2. P wave abnormality. P wave abnormalities: right atrial hypertrophy. A P wave in lead 2 taller than 2.5 mm, 2.5 small squares. The P wave is usually pointed. P wave abnormalities. Left atrial abnormality, dilatation or hypertrophy. M-shaped P wave in lead 2. Prominent terminal negative component to P wave in lead V1. P wave abnormalities: premature atrial complex, PAC. An abnormal P wave, arrowed in figure below. As P waves are small and rather shapeless, the difference in a pack is usually subtle. The one shown here is a clear example. Occurs earlier than expected. Followed by a compensatory pause, but not a full compensatory pause. P wave abnormalities: hyperkalemia. The following changes may be seen in hyperkalemia. Small or absent P waves. Atrial fibrillation. Wide QRS. shortened or absent Saint segment, wide, tall and tented T waves, ventricular fibrillation, P-wave abnormalities, arrhythmias, will cover later. Premature atrial complex, PAC, atrial flutter, atrial fibrillation, paroxysmal reentrant tachycardia, SVT, multifocal atrial tachycardia, PR interval, normal PR interval, 0.12 to 0.20 s, 3 to 5 small squares, PR interval abnormalities, shorter PR interval, Wolff-Parkinson-White syndrome, short PR interval, less than 3 small squares, 120 ms. Slurred upstroke to the QRS indicating pre-excitation, delta wave. Broad QRS. Secondary Saint and T wave changes. PR interval abnormalities. Long PR interval, will cover later. Avenue blocks, QRS complex. QRS axis. Normal duration of complex is less than 0.12 s, 3 small squares. No pathological Q waves. No left or right ventricular hypertrophy, axis. Using leads I and AV, the axis can be assigned to one of the 4 quadrants at a glance, axis, normal. Both I and AV plus V equals normal axis. Lead I plus V and AV if the axis is in the left quadrant, take your second glance at lead 2 plus V equals normal axis, lead 2, V equals left axis deviation. Axis, left axis deviation. Left anterior hemiblock. Left ventricular hypertrophy. Q waves of inferior myocardial infarction. Artificial cardiac pacing. Emphysema. Hyperkalemia. Wolff-Parkinson-White syndrome, right-sided accessory pathway. Tricuspid atresia. Ostium primum ASD. Injection of contrast into left coronary artery. Axis, Northwest Territory. Both I and AV equals axis in the Northwest Territory. Causes of no man's land. Emphysema. Hyperkalemia. Lead transposition. Artificial cardiac pacing. Ventricular tachycardia. Axis, right axis deviation. Lead IV and AV plus V equals right axis deviation. Causes. Normal finding in children and tall thin adults, right ventricular hypertrophy, chronic lung disease even without pulmonary hypertension, anterolateral myocardial infarction, left posterior hemiblock, pulmonary embolus, Wolff-Parkinson-White syndrome, left-sided accessory pathway, atrial septal defect, ventricular septal defect, wide QRS complex right bundle branch block. Wide QRS, more than 120 ms, 3 small squares. Secondary R wave in lead V1, RSR. Other features include slurred S wave and lateral leads and T wave changes in the septal leads. Wide QRS complex. Wide QRS complex left bundle branch block. Wide QRS, more than 120 ms, 3 small squares. M-shape QRS, RR, wide QRS complex. Wide QRS hyperkalemia, changes that can be seen. Small or absent P waves. Atrial fibrillation. Wide QRS. Shortened or absent Saint segment. Wide, tall and tented T waves. Ventricular fibrillation. Wide QRS. Ventricular rhythm, will cover later. Pathological Q waves greater than 1 mm. Their depth greater than 25% of the height of the QRS. Q waves in V6 and AV, not pathological, small. Look for anatomical site, ignore AV. Pathological Q waves. Non-Q wave ME. Not all MEs develop Q waves, up to 1/3 never do, or they develop and resolve. Why? Infarct was not complete, transmural. Infarct occurred in an electrically silent area of the heart, where an EKG cannot record the injury. Acute infarct, Q waves will eventually appear. Right ventricular hypertrophy, RVH. Right axis deviation. Deep S waves in the lateral leads. A dominant R wave in lead V1. Left ventricular hypertrophy, LVH. Soklo plus Lion, Amhart J, 1949 37 to 161. S in V1 plus R in V5 or V6 greater than 35 mm. Cornell criteria, circulation, 1987 3, 565 to 72. S in V3 plus R in AV greater than 28 mm in men. S in V3 plus R in AV greater than 20 mm in women. Framingham criteria, circulation, 1990, 81 to 815 to 820. R in AV greater than 11 mm, R in V4 6 greater than 25 mm. S in V1 3 greater than 25 mm. S in V1 or V2 plus R in V5 or V6 greater than 35 mm. R in I plus S in 3 greater than 25 mm. LVH. Increased amplitude in height and depth. QT interval. Calculate the corrected QT interval, QTC equals QT, RR equals 0.42, normal equals 0.42s. Long QT interval causes myocardial infarction, myocarditis, diffuse myocardial disease, hypocalcemia, hypercalcemia, short QT, hypothyroidism, subarachnoid hemorrhage, intracerebral hemorrhage. Drugs, for example sotalol, amiodarone. Heredity, Saint segment. Normal Saint segment. No elevation or depression, Saint elevation. Causes of elevation include acute ME, e.g. anterior, inferior, lateral. LBBB. Acute pericarditis. Normal variants, for example athletic heart, high takeoff. Acute ME, look for reciprocal changes. Saint elevation in leads where ME occurs. Look for reciprocal changes. For example and ME, look for Saint depression in inferior leads. Locating the damage. Location, 12 lead. Saint depression. Causes of depression include myocardial ischemia, digoxin effect, ventricular hypertrophy, acute posterior ME, pulmonary embolus, LBBB. Digoxin effect. Characteristic downsloping Saint depression dysrhythmias. Shortened QT interval. Characteristic downsloping Saint depression dysrhythmias. Ventricular, atrial prematuretes. PAT, paroxysmal atrial tachycardia, with variable avenue block. Ventricular tachycardia and fibrillation. Many others. Acute posterior ME. The mirror image of acute injury in leads V1 to 3. Fully evolved, tall R wave, tall upright T wave in leads V1 V3. Usually associated with inferior and or lateral wall ME. Mirror test. Once you have determined an inferior, or other, ME has occurred, you begin looking for reciprocal changes. If there is Saint depression in V1, V2, and V3, flip the EKG over and hold it up to the light. Now read those leads flipped over. Are there significant Q waves? Is the Saint segment elevated with a curved appearance? Are the T waves inverted? Answering yes tells you, there is a posterior infarct as well. Saint depression in diagnosis with ischemia. Looking for at least 1 mm, 1 square. This can be 1. Upsloping. 2. Horizontal, can be combined W/1 or 3. 3. Downsloping. T waves. Repolarization of the ventricles is signaled by the T wave. Tall T waves. Causes: hyperkalemia, hyperacutemy, LBBB. Small, flattened or inverted T waves. Causes are plenty: ischemia, age, race, hyperventilation, anxiety. LVH, drugs, pericarditis, IV conduction delay, RBBP. Electrolyte disturbances. The most important thing to consider is inverted T waves associated with ischemia. Common arrhythmias. Sinus bradycardia less than 60 bpm. If profound, could have decreased cardiac output. Treatment: none if uncomplicated, atropine, pacing. Sinus tachycardia greater than 100 bpm. Myocardial oxygen demand and may coronary artery perfusion resulting in angina in CAD. Decreased cardiac output could be exhibited. SSS, sick sinus syndrome. Deceased cardiac output, related to periods of excessive bradycardia, avenue block and/or tachycardia. Treatment: pacemaker. Anticoagulation therapy. A trial premature can be in a healthy heart or with CAD. They are well tolerated because cardiac output is not altered. A trial flutter saw-toothed pattern, 200-350 bpm. A trial rate can convert to atrial fibrillation, atrial flutter, COMTED. People can feel flutter sensation. If short-lived, then no complication. However, with an increased ventricular rate, people can experience decreased cardiac output. Treatment: verapamil, vagal stimulation, digoxin, perhaps in combo with other drugs, cardioversion or pacing. Atrial fibrillation. Chaotic atrial dysrhythmia. A trial rate can be 350 plus bpm. Higher ventricular response equals cardiac output. Treatment: drugs, digitalis, verapamil, beta blocker, anticoagulation therapy, cardioversion. Paroxysmal atrial tachycardia or supraventricular tachycardia. High ventricular rate. Inadequate ventricular filling time, decreased cardiac output, and inadequate myocardial perfusion time. Treatment: prevent CHF, carotid sinus massage to stimulate vagal response, cardioversion, drugs, verapamil, propranolol, and digoxin, multifocal atrial tachycardia. Irregular rhythm with multiple, at least 3, P-wave morphologies in same lead with an irregular and usually rapid ventricular response. Pulmonary disease, hypoxia. Rate is greater than 100 bpm. Treatment: verapamil, resolve causative disorder. First degree avenue block PR greater than 120 msec. No hemodynamic complications. Could progress to higher avenue blocks. Second degree avenue block Mobitz type 1, Wenckebach. PR interval progressively lengthens with each beat until it is completely blocked. If bradycardic, could have decreased cardiac output. Treatment: only if brady, atropine, rare pacemaker. Second degree avenue block Mobitz type 2. Rare, occurs with large ANTME. PR interval fixed and P waves occur in a regular ratio to QRS. A trial rate is regular, until conduction is blocked. Second degree avenue block Mobitz type 2, COMTED. Symptoms of decreased cardiac output occur with slowing ventricular rate, could progress to complete block. Treatment: atropine initially, permanent pacemaker. Third degree avenue block, complete. Atria and ventricles are independent of each other, no relationship present. Symptoms could include lightheadedness or syncope from decreased rate. Third-degree avenue block, complete, COMTED. Decreased cardiac output, compromised coronary perfusion. Treatment. Emergency. Atropine. Pacemaker. Junctional escape rhythm. QRS complexes are not preceded by normal P waves, because the impulse originate below the SAR node. Can cause a missed P wave, inverted or in the QRS. Ventricular escape rhythm. Wide QRS complex, greater than 120 ms. Decreased cardiac output, lightheadedness and syncope due to decreased heart rate. Treatment. Atropine. Electronic pacemaker. Premature ventricular contraction, PVC. Occasional PVCs have minimal consequences. Increased frequency or multifocal PVCs can lead to ventricular tachycardia. Make sure it does not progress to more PVCs. Couplet is 2 PVCs in a row. Triplet is 3 PVCs in a row. Ventricular bigeminy. Premature ventricular contraction, PVC, in a bigeminal pattern. Can be trigeminy, every third is a PVC, quadrigeminy. Can be multifocal, increased irritability of the ventricle could lead to more severe dysrhythmia. Ventricular tachycardia, VT. More than 3 PVCs in a row greater than 100 bpm. Wide QRS, avenue dissociation, QRS complex does not resemble typical bundle branch block. Irritable ventricle. Sustained VT is an emergency rhythm and could convert to ventricular fibrillation, VT. Decreased cardiac output, irritable ventricle. Treatment. Cardioversion, lidocaine or procainamide to get NSR, emergent care, long-term care, ICD, implantable cardioverter defibrillator. Torsades de points form of VT, twisting of the points. People with prolonged QT interval are susceptible. Ventricular fibrillation. Chaotic activity of the ventricles. No effective cardiac output or coronary perfusion. Associated with severe myocardial ischemia. Life-threatening, death occurs within 4 minutes. Treatment. Immediate defibrillation. CPR, lidocaine, bretylium. Epinephrine. Sinus arrest. How to read the ECG. Look at the whole tracing. Rhythm. Is there a P wave before each QRS complex? Yes, sinus rhythm number avenue junctional or heart block. Rate, count boxes, use caliper, ruler. PR interval, normal, 0.20 seconds or less. QRS complex, skinny, 0.10 seconds or less, or broad, BBB or ventricular. Saint segment, isoelectric, normal, elevated or depressed. T wave, upright, flat or inverted. Interpretation, normal or abnormal. Is the rhythm dangerous?